Well, hello everyone. My name is Mirvat Al-Aslaj and I'm an interventional cardiologist practicing in Saudi Arabia. And welcome to another episode of EIJ on Air. With me is Hala Kakar. She's a PhD candidate at Erasmus University in Rotterdam. And today we're going to be discussing immediate or staged complete revascularization in patients presenting with acute coronary syndrome by number of diseased vessels, a sub-study of the BioVasc randomized trial. Hala, welcome aboard the EIJ on Air.
Hi, Mirvat. Thank you for the invitation.
And I just want to remind our viewers and followers that you can please ask any questions using the hashtag EIJ on Air. So just as a quick refresher of the BioVasc study that was published almost a year ago, March 2023, it aimed to investigate whether PCI for non-culprit lesions should be attempted during the index procedure or stage, something very practical for us. That was a prospective, open-label, non-inferiority randomized trial, multi-center across Europe. And so patients with a STEMI or non-STEMI were actually included in this trial. And they looked at multivessel disease with a diameter of 2.5 or more and a stenosis of more than 70%. The primary outcome of that trial, and what I'm going to do here is quickly put up the results so you can have a look at them as a refresher. So what you do see is the primary outcome, a composite of all-cause death, MI, unplanned ischemia-driven revascularization, or stroke at 1 year for immediate versus staged complete PCI, and all-cause death and subsequent myocardial infarctions. So repeat MI and unplanned revascularization occurred in staged group prior to scheduled elective PCI, and the data built upon the findings of the complete and the culprit trial, which had been published several years ago, excluding, of course, shocked patients. But here, what we're going to do now is look at a special sub-study that was, published by Hala Kakar and her colleagues. So Hala, as we move into your sub-study, when you were doing the sub-study, did you have any thoughts ahead of the results of what you thought you would find?
Thank you for the question. So yeah, of course, when we started the study, we expected three vessel disease is a more extensive coronary artery disease in which more complications could be there, and it's because of the extensiveness of it, we expected it to be harder when you do it in an immediate setting. So therefore, we thought if you do it in an immediate setting, there might be more contrast, more radiation, more procedural duration. So therefore, it might be harder in that way, especially when a patient comes in the night with a STEMI and then three vessel disease. Immediate setting would be harder for some operators too. Therefore, we conducted this sub-analysis. But it was actually against expectations. The immediate setting was actually as good as the stage setting. We did not identify any adverse events which were more in the immediate setting. And therefore, it was actually unexpected, but nice to find.
So if we could just backtrack a little bit and go over the design and safety and efficacy endpoints of the sub-study, could you just walk us through that a little bit?
Yes, of course. So what we did is we divided the patients in two vessel disease and three vessel disease, in which the two vessel disease population was a lot more. It was 1,177, and the three vessel disease group was 265 patients. And then in these two subgroups, we compared the two settings. So we looked at immediate complete revascularization versus the staged complete revascularization, and we also compared the two with each other. So that's how we did it, and then we looked at a primary endpoint consisting of a composite endpoint of all-cause mortality, myocardial infarction, ischemia-driven revascularization, and cerebrovascular events. And a combination of that, and then we looked at 1 year follow-up.
So what were the most relevant findings of your sub-study? And as a follow-up to that, would you consider that immediate revascularization benefit a certain category of patients with multivessel disease only, or all multivessel disease? I mean, do you suspect that, for example, syntax score or complexity of the anatomy is probably more valuable or than just the number of vessels? So I'll really quickly show your results as well for our viewers, and maybe you can walk us through some of these.
Yeah, so the most important results were, of course, that first of all, we did not find any significant difference between the primary endpoint between two vessel and three vessel disease, immediate versus staged. That was very interesting because it was against expectations. And also we found that in both groups, we saw that there is a substantial difference in myocardial infarction. So it was significant in the three vessel disease group, which means that there were a lot more in the stage group versus the immediate group. While in the two vessel disease group, we did find a trend, but it was not significant. So that was very interesting to see.
Did you notice any other patterns? So, were there any notable trends according to other subgroups like sex or the type of acute coronary syndrome, for example, non-STEMI versus STEMI, or the vessel that was involved? So, left anterior descending artery as opposed to right coronary artery, for instance.
So we did look at these individual components and we did not see any differences. So we did not see that sex had any impact. Of course, we did have a lot more males than females in the trial, unfortunately. And the same goes for the other components. They did not have an impact. Also, the BIFAS trial also earlier showed that looking at any of the vessels, LAD, LCX, or RCA, it did not matter. So it did not affect the results. And coming back to a part of your previous question, which I went too quickly over, syntax score would, to my opinion, I think it would impact more than the number of vessel disease. Of course, three vessel disease would have a higher syntax score due to one extra vessel, maybe some more complex lesions. So therefore, I think that the syntax score would be the most important factor indeed. So that's what I agree.
So, yeah, do you think the sub-study was powered to give us enough sub-analyses, or were there not enough events in the overall cohort? What do you think?
No, so I do think we were underpowered. Of course, it's interesting that we already found a significant difference in the three vessel disease group with such low events. But we were underpowered for other sub-analyses. So we did look at other like the non-STEMI versus STEMI, but we were underpowered to show any difference.
You know, another thing I noticed in your data, in some of the tables that were really elegantly put together, is that you mentioned off-hour procedures as well. You actually looked
Yes.
at off hours. Did that at all impact your results?
No, so that was also interesting. So what we expected was that in the off-hour group, it would have a huge impact because people come in the night with a STEMI, three vessel disease. Operators have to handle that quickly, but we do not see any differences. So at least our data did not show that. So no, it did not impact our results. So therefore, we do not see any reason to think that in the night it would be worse than during the day. But of course, that's also due to operators' discretion. So if an operator is very experienced, they might do everything at once. But if an operator thinks it's better to stage it, then of course they are welcome to stage it too.
Yeah. So, you know, when we're looking at the results and we're trying to kind of absorb them and dissect them a little bit, how do we explain a lower rate of myocardial infarctions in those who got immediate revascularization for three vessel disease and only a trend towards significance in those with two vessel disease?
So our hypothesis is, it's only a hypothesis, but we think that we don't have enough events and enough patients. So we're underpowered to show any difference. But we do think if we had more patients, it would be possible that we did see a significant difference. So there is a trend, but it's a 0.05 trend. So it's quite on the borderline. So it might be if we had a little more patients, we could show a significant result. So I think that's the reason.
Another thing that actually one of our viewers is asking is about clots and so on that we can identify. And this is a question that is coming in from, just reading the name properly, from Salman Sam on YouTube. And he's saying, what about clots in non-culprit vessels in those with acute coronary syndrome? Did that at all impact your outcomes?
So unfortunately, we didn't have a lot of imaging, which would have been very important in this case to see if a clot indeed has a huge impact, but we don't have data on that. I do think that, especially in the three vessel disease group, that's why it's a little harder. You have a harder culprit in the identification in the non-STEMI patients. And in the STEMI patients, you have more vulnerable plaques, unstable lesions, which might cause more events in the stage group in a later phase due to the time in between. So it might have an impact, but we don't have enough data to show it, unfortunately.
Yeah, so I just want to kind of emphasize that a little bit because the complete trial, for example, looked at complete versus culprit only. Unlike BioVask, it didn't actually look at even for those who got complete, whether it was immediate or late, but they did have a sub-study, which was the complete OCT that actually looked at intracoronary imaging and identified, lesions that were probably vulnerable and so on. But that was a very small number of patients, even in the complete. It was at best hypothesis generating and not, I don't think we can build solid conclusions from it. But do you think, had there been higher uptake of intracoronary imaging in BioVask,
Yes.
would you have seen differences between two vessel disease, three vessel disease?
Yes, that's a very good question. So it's something we thought a lot about. Yes, we do think so. We think imaging is very important, very upcoming, and very important to use more. I think we would have actually known the reason why three vessel disease shows a significant difference and why there are certain plaques in STEMI population, which in the complete trial showed that there are vulnerable plaques. You see which is the actual culprit lesion in the non-STEMI patients, which might have been misidentified in these cases. With more imaging, it would be possible to have a good analysis of everything, actually. So I do think it would have a major impact on the results.
Absolutely. We may, the easiest explanation would be we may end up converting some of the two vessel disease into three vessel disease that we otherwise by, just naked eye and angiography alone would have considered it as a two vessel disease.
Yes, exactly.
So, you again mentioned something that I think is very valuable and very practical to operators, which is looking at procedure time, contrast use, radiation. And although it may have been slightly longer in those with three vessel disease and so on, it didn't really translate into a difference in meaningful hard endpoints. What are your thoughts there?
I'm sorry, I didn't quite understand the question.
So, you did mention that for immediate complete revascularization, you do anticipate that some of these patients will have a longer procedure time, more contrast use, and so on. But that didn't really impact overall clinical events, right?
No, it didn't. And also, we did not find that. So the interesting part is we did expect that it was more in the immediate group in every sense of the procedure, also in the three vessel disease, but we did not find that. Interestingly, you had in the immediate arm, you had a lower procedure time, you had lower contrast use and lower total area dose, which means at the end that that's a positive thing to see, that everything was lower and also significantly. So that was very interesting, and it did not cause any extra events indeed. We did not see any differences in that.
Yeah. Well, thank you, Hannah, very much. And, this was very insightful discussion with you on the sub-study of BioVask, looking at the different number of vessels, whether two vessel disease compared with three vessel disease would really impact the important endpoints from the BioVask trial. For me, an important signal that we saw in the BioVask was that although immediate complete revascularization was non-inferior to staged, for the primary composite endpoint, there was a reduction in the rate of myocardial infarctions and unplanned ischemia-driven revascularization. And so I think it warrants more, sub-analyses and speculation and so on. And perhaps that is why we need sub-studies like yours. So what really drove, or what was that signal coming from? Was it coming from the number of vessels, syntax score? I do see one more question that came in from our viewers and audience. How about chronic total occlusions in non-culprit lesions? What should be the approach based on the data from BioVasc, in your opinion?
Unfortunately, those are the patients we excluded from the study. So we do not have data on the chronic total occlusions patients, which is a very specific group of patients with very complex disease. And I think we need better trials for that, which we don't have yet, but hopefully soon there will be more.
So again, thank you very much. And I appreciate the engagement of the audience who are directing questions. But I'm sure there's a lot to learn from BioVasc and all the sub-studies that came through. And we're hoping to learn a little bit more about those signals and what they mean for us in clinical practice. Hannah, any closing thoughts from your end?
Important to know for every operator is that immediate or stage is really your choice. It's both safe to apply, and I think it's per patient to conclude which one you want to use, but both are can safely be adopted. Thank you very much for the invitation, and it was an honor to be here.
My pleasure, and thank you, EIJ, and hoping to see our audience one more time in the next episode that's coming up.